Welcome back, everyone. We will begin our next session on the COVID-19 vaccines, and our introduction will be started by Dr. Schechter.
Thank you, Dr. Talbot. Good morning. Next slide, please. To recap, in August 2024, the U.S. Food and Drug Administration authorized and approved the 2024-2025 COVID-19 vaccines, including 2 mRNA-based vaccines from Moderna and from Pfizer-BioNTech in persons at least 6 months of age, and the protein-based Novavax vaccine in persons at least 12 years of age. Next slide. Last year, ACIP made recommendations for everyone aged at least 6 months to receive 2024-2025 COVID-19 vaccination. Specifically, children aged 6 months through 4 years need multiple doses to be up to date, including at least 1 dose of 2024-2025 COVID-19 vaccine. People aged 5 to 64 years should get 1 dose, and people who are either at least 65 years or who have moderate or severe immunocompromise and at least 6 months of age should receive a 2nd dose of 2024-2025 COVID-19 vaccine 6 months after their first dose. And people with moderate or severe immunocompromise may receive additional doses of 2024-2025 COVID-19 vaccines under shared clinical decision-making. Next slide. Turning to data on COVID-19 outcomes in the last years and months. For these last 4 years of provisional weekly COVID-19 deaths in the United States reported to CDC from October 2021 through March 2025, there are trends for each subsequent year to have lower numbers of deaths. In the first 3 years, we see 2 surges per year, the first being early in the calendar year in the winter, followed by a late summer or fall surge. For the first 3 years, the winter surge was larger than both the following summer-fall surge and higher than the previous summer-fall surge in the preceding year. This pattern has changed in 2025 for the blue line at the bottom, in which the surge in the recent months in early 2025 was lower than the summer-fall surge on the right-hand side of the purple trend line in summer-fall 2024. Next slide, please. Turning from deaths to hospitalizations reported to CDC from COVIDNet, similar patterns over these last 4 years, with an early 2025 winter surge that was of smaller magnitude than the summer-fall 2024 surge in the red trend line. This raises the question about what the rest of 2025 holds. Will there be additional surges occurring at similar or different times in late summer, early fall? And will additional surges be, how will they compare to the level of disease seen in early 2025? Next slide, please. In this slide, we have estimates from CDC on illnesses, outpatient visits, hospitalizations, and deaths due to COVID-19 on the middle row, and from influenza infection on the bottom row. And with the combination of decreased amount of COVID-19 disease compared to previous years, and an influenza season that appeared to be more severe or with higher level of disease than the 2023-2024 previous season, these estimates are generally larger for influenza than for COVID-19. However, looking at the more severe outcomes towards the right-hand side of the table, the lower estimate for deaths is comparable between the two diseases, reflecting that for a case of COVID-19, a severe outcome is more probable than for any given case of influenza. A couple of other observations that even at lower levels, tens of thousands of Americans have perished with COVID-19, and that many of these are potentially vaccine preventable. And additionally, that this table covers many outcomes, but does not include post-acute sequelae or long COVID information. Next slide, please. Turning to vaccination coverage for the current formulation, in green, the 2024-2025 formulation, or the prior 2023-2024 formulation in blue. For both of these formulations, cumulative coverage for adults 18 years and older topped out by springtime at about 20% of the adult population in the United States, reflecting that there are a majority of adults in both years, including adults at older ages with higher risks of severe outcomes who have not been immunized. Next slide, please. Since the committee met last October, the work group has heard presentations on a number of topics to inform considerations for risk-based versus universal vaccine recommendations for the 2025-2026 COVID-19 vaccines. Topics including COVIDnet data for those with or without risk factors, mortality, vaccine hesitancy and uptake, vaccine safety and effectiveness, a new vaccine candidate from Moderna named mRNA-1283, seroprevalence of SARS-CoV-2 infections in the population, post-COVID conditions, multisystem inflammatory syndrome in children, and feedback from liaison organizations. Next slide. Today's session will include a presentation from Dr. Rizkallah of Moderna regarding its mRNA-1283 vaccine candidate, and from CDC presenters, Dr. Havers talking about epidemiology and risk factors for COVID-19 hospitalizations, Dr. Link Gellis on current vaccine effectiveness updates, and from Dr. Panayotopoulos, work group considerations for use of 2025-26 COVID-19 vaccines. Next slide. After today's presentations, a preliminary timeline for forthcoming 2025-26 COVID-19 vaccines includes an anticipated meeting of the FDA Vaccines and Related Biological Products Advisory Committee to review strain selection. At the next scheduled ACIP meeting in June, discussion and vote on recommended use. And by late summer or early fall, anticipated availability of the 25-26 COVID-19 vaccines. Next slide. Continued thanks to fellow ACIP members, ex officio and government members, liaisons and consultants who dedicate their time to these many meetings, and the review led by our intrepid CDC co-leads. Next slide. And gratitude as well to the large team of CDC participants who provide timely and detailed data to inform our deliberations. Thank you.
Thank you. Dr. Rizkallah, are you ready?
I am. Just give me one moment to share slides. Just confirming you can hear me okay and see the slides?
Yes, to both.
Excellent. Well, thank you for the opportunity to present this morning. My name is Bishoy Rizkallah. I am the Medical Affairs Lead for Moderna's infectious disease portfolio. Today, I will provide an update on our next generation COVID-19 vaccine, mRNA-1283. COVID-19 remains a leading infectious disease cause of hospitalization and death in the United States. When we consider where risk of severe disease is greatest, advancing age with the increasing impact of immunosenescence, and those with pre-existing medical conditions continue to be a key focus for public health. This is the basis for developing our next generation COVID-19 vaccine to enable optimal protection, particularly in those most vulnerable. While current COVID-19 vaccines present the entire spike protein, mRNA-1283 is designed to present specifically the N-terminal and receptor binding domains of the SARS-CoV-2 spike protein, which contain the key epitopes critical for eliciting potent neutralizing antibody and T-cell responses. By focusing on these important regions, mRNA 1283 achieves a streamlined vaccine design, substantially reducing the mRNA sequence length and enabling a lower dose of 10 micrograms, which is just 1/5 of the Spikevax dose. This innovation positions mRNA 1283 as the foundation for future combination vaccines, such as mRNA 1083, Moderna's investigational flu-COVID combination vaccine. For context, over the past 5 years, mRNA 1283 has been evaluated in a comprehensive clinical development program spanning phase 1, 2, and 3 studies. Today, I'll focus specifically on the pivotal phase 3 study, assessing its safety, immunogenicity, and efficacy. Study 301 is a randomized, blinded, active control phase 3 trial. Participants aged 12 years and older were randomized 1-to-1 into 2 groups to receive either mRNA 1283 or to receive mRNA 1273, which is commercially known as Spikevax. Both vaccines are bivalent formulations targeting the original SARS-CoV-2 strain and Omicron BA.4/5 variants, reflecting the updated vaccine recommendations at the time of enrolment in 2023. The study's primary objectives are threefold: to assess safety and reactogenicity, to demonstrate non-inferior neutralizing antibody responses, and to demonstrate non-inferior relative vaccine efficacy for the prevention of CDC-defined COVID-19. The demographics and baseline characteristics were well balanced between the groups across age, race, and ethnicity. The median age was 56, with approximately 29% of participants aged 65 years and older. The study demographics are largely representative of the United States, with 76% of the overall study population recruited here in the US. Nearly half of the study population had a chronic condition classified by the CDC as being associated with severe COVID-19 outcomes, including conditions such as diabetes, heart disease, and asthma. Prior COVID-19 vaccination and SARS-CoV-2 infection history was also balanced between the two groups. Approximately 3/4 of study participants had a prior infection, which is consistent with the epidemiology at the time of enrolment in 2023. Most participants had also received 3 or 4 prior COVID-19 vaccines, with the last dose being a median of 9.8 months prior to enrolment. Transitioning now to the results, starting with safety. Local and systemic reactions to both study vaccines were evaluated for 7 days post-vaccination. All unsolicited adverse events were monitored for 28 days. In addition, medically attended adverse events, serious adverse events, events leading to discontinuation, and events of special interest, including myocarditis and pericarditis, are monitored for the duration of the study, which is 1 year. The study was overseen by an external, independent, unblinded data and safety monitoring board. The median safety follow-up in this study was 8.8 months. Here are the solicited local events within 7 days of vaccination, with mRNA 1283 on the left in light blue and Spikevax on the right in dark blue. The most common local reaction was pain, which trended lower when compared to Spikevax. Local adverse reactions were mostly grade 1 and grade 2 and transient in nature, with a median duration of 1 to 2 days. Solicited systemic events were similar in frequency between the two groups, with fatigue noted as the most frequent event. Most events were grade 1 and 2 and transient, with a median duration of 1 to 2 days. Presented here are the unsolicited adverse events within the first 28 days after injection. Serious adverse events medically attended events, events leading to discontinuation, and events of special interest were balanced between the two groups. So to summarise safety through the median follow-up of 8.8 months in this analysis, we have not observed any imbalances in adverse or serious adverse events between the vaccine groups. There were no reports of myocarditis or pericarditis. No safety concerns were identified. Turning now to immunogenicity. This slide presents the primary immunogenicity endpoints for mRNA-1283 versus Spikevax at day 29. Neutralizing antibody responses and geometric mean ratios are shown at the top, while seroresponse rate differences are displayed at the bottom. This study achieved all pre-specified immunogenicity objectives. For geometric mean ratios, the lower bound of the confidence intervals were above 0.667, surpassing the non-inferiority threshold. In fact, the lower bound was above 1, indicating higher neutralizing antibody responses with mRNA-1283 compared to Spikevax. Likewise, the lower bound for the difference in seroresponse rates was above -10%, meeting the criteria for non-inferiority. Notably, the lower bound was above 0, which again indicates higher seroresponse rates with mRNA-1283. This slide presents the BA.4/5 neutralizing antibody responses for mRNA-1283 versus Spikevax at day 29, broken down by age groups. The bar graphs illustrate neutralizing antibody responses with the corresponding geometric mean ratios displayed above each data set. Both vaccines elicit strong immune responses in adolescents, with a geometric mean ratio of 1.0. Notably, the relative neutralizing antibody responses with mRNA-1283 versus Spikevax increases with age, with the highest geometric mean ratio observed in adults 65 and older, with a ratio of 1.8. mRNA-1283 consistently sustains higher neutralizing antibody responses compared to Spikevax over time. While this trend is evident in the overall study population, shown here are the neutralizing antibody responses against Omicron BA.4/5, specifically in adults aged 65 and older, a group at increased risk for severe COVID-19 outcomes. Geometric mean ratios and antibody levels are presented at day 29, month 3, and month 6 post-vaccination. As illustrated, mRNA-1283 elicited higher antibody responses than Spikevax at day 29 and sustained these higher responses through at least 6 months. Notably, antibody levels at 6 months with mRNA-1283 remained higher than those achieved by Spikevax even 3 months earlier at day 91. Up to this point, we've discussed data from our pivotal safety and efficacy study evaluating the bivalent BA.4/5 vaccine, which was the recommended formulation at the time of trial enrolment in 2023. Additionally, we assessed immune responses to a monovalent XBB 1.5 vaccine in a separate study conducted in Japan, which, like the pivotal efficacy study, included participants aged 12 years and older. In this study, the monovalent formulation met the non-inferiority margin. Notably, the lower bound of the confidence interval again exceeded 1, consistent with the pivotal efficacy study findings indicating higher neutralizing antibody responses elicited by mRNA-1283 compared to Spikevax. These results demonstrate that mRNA-1283 elicits consistent immune responses whether formulated as a monovalent vaccine or as a bivalent vaccine. Turning now to the primary objective of relative vaccine efficacy. The primary relative vaccine efficacy objective was evaluated using the CDC case definition of COVID-19, requiring a positive SARS-CoV-2 PCR test and at least one clinical symptom consistent with COVID-19, as listed here on the slide. Surveillance was conducted using bi-weekly electronic diary prompts. Presented here are the relative vaccine efficacy results over a median follow-up of 8 months. The study met the pre-specified non-inferiority criteria for success, defined as the lower bound of the confidence interval exceeding minus 10% relative efficacy. mRNA 1283 demonstrated a relative efficacy of 9.3% compared to Spikevax for the prevention of CDC-defined COVID-19. This slide presents the relative vaccine efficacy of mRNA 1283 versus Spikevax across pre-specified age groups. In adults, we see a trend of increasing relative vaccine efficacy with advancing age, reaching the highest point estimate of 13.5% in those aged 65 and older. In adolescents, comparable immune responses between mRNA 1283 and Spikevax support the expectations of similar protective efficacy, although the smaller sample size, lower attack rate, and fewer cases led to an imprecise point estimate with wide confidence intervals. Overall, the efficacy data align closely with our earlier immunogenicity findings. Adults aged 65 and older showed the highest relative neutralizing antibody levels, and correspondingly, the highest point estimate for relative vaccine efficacy. Nearly half of the study population had at least one CDC-defined comorbidity associated with increased risk of severe COVID-19 outcomes. This slide presents a post-hoc analysis assessing relative vaccine efficacy of mRNA 1283 compared to Spikevax in individuals at progressively higher risk due to underlying health conditions. The top row shows efficacy in participants with at least one CDC-defined comorbidity. Subsequent rows examine the combined effects of age and comorbidity together, highlighting their cumulative impact on COVID-19 severity. The relative efficacy of mRNA 1283 increases across these higher risk subgroups, with the greatest benefit observed among adults 65 and older that have at least one CDC-defined at-risk comorbidity. While this study was not powered to assess severe COVID-19, and there were too few cases to evaluate efficacy based on hospitalizations, we conducted a post-hoc analysis using the FDA-defined criteria for severity. A total of 55 cases met the criteria for severe COVID-19, with approximately 93% classified as severe due to blood pressure or oxygen saturation abnormalities. mRNA 1283 demonstrated a relative vaccine efficacy of 38.1% for the prevention of severe COVID-19 compared to Spikevax. This suggestion of improved protection against severe COVID-19 and also the relative efficacy in those with comorbidity needs to be validated in future real-world effectiveness studies. So to summarize, the data presented today demonstrate that mRNA 1283 is generally well tolerated with no safety concerns identified. The study met its primary non-inferiority endpoints for immunogenicity and relative vaccine efficacy compared to a highly effective standard of care, Spikevax. While the study was designed to demonstrate non-inferiority, we observed higher immune responses with advancing age and a trend for higher vaccine efficacy with a positive point estimate in adults with advancing age and in those with chronic conditions associated with poor COVID-19 outcomes. Together, these findings underscore the potential of mRNA 1283 as a critical tool to further reduce the burden of COVID-19, particularly amongst those at highest risk. We present this data today to support the consideration of mRNA-1283 for the inclusion into future COVID-19 vaccine recommendations. The PDUFA date is anticipated by the end of May, and we plan to supply mRNA-1283 as an option for COVID-19 prevention this upcoming fall. The vaccine formulation will be updated to match the circulating SARS-CoV-2 variants when recommended by the FDA. With that, I'd like to thank you for your attention, and I'd like to thank all the individuals and colleagues who made these studies possible. We'll be happy to take any questions.
Thank you. Any questions? Dr. Asturias.
Yes, and thank you for that presentation. And this is probably an unfair question, but one that I still want to sort of explore. Is the lower antigen in this vaccine sort of suggesting anything in terms of perhaps now that most of the population is naturally or vaccine protected and immunized, and a better sort of lower antigen in this vaccine, a better sort of a strategy than the higher dose 5-vax that we have used in the past. Perhaps now that most of the population is naturally or vaccine immunized, There was a lot of echo. I don't know if you want me to repeat the question.
That would be great. Thank you.
All right. So the question is, would you sort of try to explore the issue?
I'm sorry, we seem to be missing audio from the Zoom. Can you still hear me okay?
I can hear you fine.
We can hear you well.
Can you hear me? Yes. Dr. Asturias, can you hear us here?
I can hear you well.
Okay. Would it be possible to email Dr. Roscoe?
Yep, we can hear you.
Can you hear us now?
We lost you for a little while. Yes.
Okay, fantastic.
Okay.
Dr. Asturias was actually going to re-ask his question, so now that you have audio again, we'll let him start.
Yes, please. Thank you.
So again, my question was regarding the use of a fifth of antigen dose in this new formulation of the vaccine, and for you to give some perhaps a bit of an insight that is this now potentially a better strategy given the immunity, natural or vaccine induced, that we have had in most of the population, versus the traditional sort of a high dose antigen that you had previously. And the reason I'm asking this is because we have seen this with other vaccines where, boostering a lower dose may be much better than the traditional dose.
Thank you for your question. So the receptor binding domain and the N-terminal domain have been well described as really harboring the key epitopes that are critical for neutralizing antibodies and cell-mediated immune responses. What we've been able to demonstrate clinically is that at a fraction of a dose, we're able to achieve higher levels of neutralization with mRNA-1283 with this construct by comparison to a spike-based protein antigen design. Now, we've got a variety of clinical and non-clinical work that has gone to describe this further. So a variety of various compositions made up of various variants clinically. So original SARS-CoV-2, beta, we've looked at various Omicron variants, including BA1, BA45, XBB 1.5, and non-clinically, we've looked at recent variants as well, such as JN1 and KP2. Now, what remains consistent throughout all those investigations is this consistent pattern that mRNA-1283 outperforms Spikevax in terms of its ability to induce higher neutralizing antibodies. But ultimately, that's why we've conducted an efficacy study to show that this intrinsic relationship between neutralizing antibodies translates into efficacy and protection, which we've been able to demonstrate. So I would say we've now got an expansive body of evidence that supports a vaccine design with this construct.
Thank you. We're running a little behind, so I'm going to ask Dr. Shaw, Dr. Sinaias, and Ms. Moser to ask their questions quickly. And then please, everyone else has their hand held. We're going to try to come back to this as long as Dr. Rizkallah can stay on the line. Dr. Shaw?
Okay, thanks. Thanks for that presentation. I'll do two questions. I think I saw there was one fatal event in the Spikevax group, if you wanted to comment on that. And I think my other question was if there are any inhomogeneities in either history of prior COVID or vaccination history in the groups, which we know both can affect immune responses. Thanks.
I'll answer the second question first, and then I'll ask my clinical colleague, Dr. Shalkas, to take your first question. So in terms of responses based on prior doses of COVID-19 responses, we were able to look at that through sensitivity analysis in our data set. We've looked at it both in terms of immune responses and efficacy. And what we've been able to show is that mRNA-1283 induces higher immune responses versus Spikevax, regardless of the number of prior doses that an individual has received. And that translates into a consistent efficacy, largely reflective of that immune response. And efficacy is maintained and in line with the primary analysis that was presented today. But in terms of your first question, Dr. Shalkas, do you want to take that question?
Yes, hi, this is First Shalkas from Moderna. Indeed, there were no fatal events in the 1283, the investigational vaccine group, and there was one fatal event in the Spikevax group. This pertains to a 77-year-old female with history of cardiovascular disease. It was a sudden death that happened within a week after immunization, and the investigator considered that event as unrelated and attributed the event most likely to the underlying cardiovascular illness. Thank you.
Thank you. Dr. Sinaias.
Thank you. Your studies included patients with greater than one comorbidity. Did it include immunocompromised patients?
No, immune-compromised individuals were not included in the study. But we would expect largely, given a common platform with Spikevax and the immune responses that we see, that the vaccine will perform in a similar magnitude to Spikevax.
Thank you.
Ms. Moser.
Thank you. The potential for higher and more durable immune responses in older people is good to see. But I'm wondering if you could comment on the similar rates of adverse events, even though there was a lower dose used in the newer vaccine.
Yeah, so both vaccines really induce a robust immune response, and we wouldn't necessarily expect to see necessarily differences in systemic events with two robust immune response vaccines that induce robust immune responses. We do see, however, a trend for lower local reactions. That might be largely explained by two factors. One, the lower dose of mRNA-1283, but also a smaller injection volume with mRNA-1283. So it's 10 micrograms administered in 0.2 ml with mRNA-1283 versus Spikevax, which is 50 micrograms administered in 0.5 ml. That might be the reason why we see a trend for lower local events.
Thank you. We will continue with these questions after the last presentation of this session. So hang tight, I haven't forgotten you. We're going to move on to epidemiology and risk factors by Dr. Havers.
Thank you, Dr. Talbot. Next slide. Today I'll be discussing recent trends in the epidemiology of severe COVID-19, largely using data from the COVID-19 Associated Hospitalization Surveillance Network, or COVIDNet. COVIDNet is one of 3 ResMed platforms, in addition to RSVNet and FluServeNet, that collect data using similar methods and catchment area on laboratory-confirmed COVID-19 RSV, and influenza-associated hospitalizations, respectively. COVIDNet is a population-based surveillance system that collects data on hospitalizations from more than 300 acute care hospitals in 98 counties across 13 states, and the catchment area covers about 10% of the US population. Hospitalizations reported to COVIDNet include all those where a positive SARS-CoV-2 test result was reported within 14 days prior to or during hospitalization. And testing for SARS-CoV-2 is driven by clinical judgment and facility policies. We collect data, including basic demographic data for rates on all patients, while detailed clinical data, including outcomes and underlying medical conditions, are collected by trained surveillance officers from an age and site-stratified random sample. Next slide. The next several slides will show hospitalization rates for COVID-19 in red, influenza in blue, and RSV in green. For ResMed, the surveillance periods extends from October through September of the following year. The inset, which shows rates since the beginning of the pandemic, is shown for context, and weekly rates for the last 2 seasons, from October 2023 through March 2025, the ongoing season, are shown in the main graph. COVID-19 hospitalization rates peak in both winter as well as during the summer, and as you can see, there was a large summer wave in 2024. This differs from RSV and influenza, which generally have a single peak in the winter. Next slide. You can see the impact of this year-round circulation in this figure, which shows cumulative rates of COVID-19, influenza, and RSV hospitalizations for the same period as the previous slide. Cumulative rates are the sum of consecutive weekly rates. Cumulative rates of COVID-19 hospitalizations for the ongoing 2024-25 season, shown in the solid red line, are lower than what was seen in the prior season, shown in the dashed red line. While cumulative rates of influenza for the ongoing 2024-25 season, shown in the solid blue line, are higher than rates of COVID-19 hospitalizations for the current season, they remain lower than last year's COVID-19 hospitalization rates. Next slide. This slide also shows that many COVID-19 hospitalizations occur outside the typical respiratory virus season of October through April, which is shown in dark red. Hospitalizations occurring May through September are shown in lighter red. In 2023-24, the period that we have the most recent complete season, a third of COVID hospitalizations took place outside the normal respiratory virus season. Based on previous patterns, we may see ongoing circulation of COVID-19 through the summer, while hospitalization rates for RSV and influenza may continue to trend down. Next slide. This figure is another way of putting recent epidemiology in context by showing cumulative rates of COVID-19 associated hospitalizations, but over multiple surveillance seasons and shown by age group, with the highest rates in infants less than 6 months on the far left and adults 75 years and older on the far right. For each age group, rates of the COVID-19 hospitalizations have decreased over time since the peak at the 2021-22 season, but cumulative rates among adults ages 75 years and older for the 2023-24 season remained higher than those experienced by any other adult age group for any previous season. Next slide. Note that different respiratory viruses affect different age groups in different ways, with the biggest collective impact at the extremes of age. This figure shows cumulative rates of laboratory-confirmed hospitalizations for COVID-19, influenza, and RSV. As you can see, RSV in green contributes to the highest burden of respiratory diseases in children less than 5 on the left. But here you can also see in red that COVID-19 has an outsized impact on older adults. This is data from the 23-24 season. Next slide. For the next several slides, I'm going to focus on the epidemiology of pediatric COVID-19 associated hospitalizations. Next slide. This figure shows the percentage of COVID-19 associated hospitalizations by age group by week from March 2020 through March 2025. For the most recent 12 months, pediatric hospitalizations, shown in green, comprised about 4% of all COVID-19 associated hospitalizations, the majority of which occur in children under 5. Next slide. This slide shows hospitalization rates by pediatric age groups for the last several seasons, starting in October 2022 through March 2025. Week after week, rates of COVID-19 hospitalizations are highest among infants less than 6 months of age, shown in the dark blue line. Next slide. So this figure is the same as the previous one, except that Infants less than 6 months who are not eligible for COVID-19 vaccines are not shown, but the scale of the y-axis is preserved. Next slide. Finally, this figure is the same as the previous one, except the y-axis is adjusted to better see hospitalization rates among children 6 months and older and who are eligible for COVID-19 vaccination. The youngest children displayed, those ages 6 months to 4 years, have the highest rates of COVID-19 hospitalization among these age groups, shown in the blue line, followed by children ages 5 to 11, shown in red, and adolescents, ages 12 to 17, shown in gray. Next slide. To put COVID-19 pediatric hospitalizations in the context of another vaccine-preventable disease, influenza, this chart shows historic seasonal cumulative rates of pediatric influenza hospitalizations, shown in blue, and COVID-19 hospitalizations, shown in red. Generally, for both pathogens, hospitalization rates are higher in children less than 5, shown in the left part of the chart, compared with rates of school-aged children and adolescents ages 5 to 17, shown on the right. Next slide. Looking more closely at the data from the previous slide, among children less than 5 years of age, for the two most recent seasons with complete data, COVID-19 hospitalization rates are comparable to influenza hospitalization rates. Next slide. However, among adolescents 5 to 17 years, in the two most recent seasons with complete data, influenza hospitalization rates have generally been higher than those due to COVID-19. Next slide. Not only do hospitalization rates vary widely by pediatric age group, but the clinical characteristics, including underlying medical conditions, of infants, children, and adolescents who are hospitalized with COVID-19 also differed by age during recent seasons, as shown on this slide. Among children and adolescents aged 6 months and older hospitalized with COVID-19, 59% had one or more underlying medical conditions, but the proportion of hospitalized children with underlying medical conditions increased with increasing age. Among children 6 to 23 months of age, less than half had an underlying medical condition, and prematurity, shown in light blue, was the most prevalent condition. Among the three older age groups, asthma and reactive airway disease, shown in gold, and neurologic disorders, in light green, were the most prevalent conditions among children hospitalized for COVID-19. Next slide. Among children who are hospitalized for COVID-19, many continue to experience severe outcomes across all the pediatric age groups. From July 2023 through March 2024, approximately 1 out of 5 hospitalized children were admitted to the intensive care unit, 41% of whom had no underlying medical conditions, although the proportion with no medical conditions varied by age group. Also during this period, 7 children with COVID-19 associated hospitalization died in hospital in the COVID-net catchment area. Next slide. This slide shows the vaccination status of children hospitalized for COVID-19 during the 2023-24 season. Fewer than 10% of children and adolescents hospitalized with COVID-19 had received any vaccine within the 12 months preceding their COVID-19 hospitalization. And additionally, fewer than 5% of the hospitalized children and adolescents had received the recommended 23-24 COVID vaccine for that season, as shown in dark blue, suggesting that many of these hospitalizations were potentially preventable had the child received the recommended vaccine. Next slide. So in summary, for pediatrics, rates of COVID-19 associated hospitalizations are highest among the youngest age groups. Although among school-age children, hospitalization rates have been higher for influenza than COVID-19. More than half of children and adolescents hospitalized with COVID-19 had more than one underlying condition, and this increased with increasing age, but a substantial proportion of children had no underlying medical conditions. And the most common underlying conditions also varied by age groups. And again, as we saw, the vast majority of children who were hospitalized with COVID had not received the most recently recommended COVID-19 vaccine during the 2023-24 season. Next slide. I'm now going to turn my focus to COVID-19 hospitalizations in adults. Next slide. As noted previously, adults comprise the vast majority of COVID-19 hospitalizations, with older adults being most impacted. This figure shows the proportion of COVID-19 associated hospitalizations by adult age groups from March 2020 through March 2025. For the most recent period, highlighted by the red box, adults aged 65 years and older comprised more than 2/3 of all hospitalizations in adults. Among adults 75 years and older comprised nearly half, 48%, of all COVID-19 adult hospitalizations, despite the fact that they make up only 9.2% of the US population. Next slide. The outsized impact on adults 75 years and older is shown in this slide, which shows COVID-associated hospitalization rates cumulatively for the 2023-24 season by age group. At 1,410 hospitalizations per 100,000 populations, this means that more than 1 out of every 100 adults 75 years and older were hospitalized with COVID-19 that year. The table on the right indicates the rate ratios relative to this 75 years and older age group. So rates among adults 75 years and older were 3 times as high as those in adults 65 to 74, nearly 9 times as high as those adults 50 to 64, and 24 times as high as adults ages 18 to 49. And the rate ratios are similar to those that we're observing in the ongoing 2024-25 period. Next slide. So similar to the pediatric slides that I showed, this chart shows historical seasonal cumulative rates of influenza hospitalizations in blue and COVID hospitalizations in red among adults. So you can see that for the past seasons for which we have complete data, generally speaking, among older adults on the right, the rates of COVID hospitalizations have generally been higher than those due to influenza. Next slide. Certain underlying medical conditions increase the risk of COVID-19 associated hospitalizations in adults. This figure shows results from an analysis led by Sarah Hamid that shows the adjusted rate ratios comparing the risk for COVID-19 associated hospitalizations among adults with a condition compared to those without that condition, using COVID-19 hospitalization data and population data from the Behavioral Risk Factor Surveillance System. Chronic kidney disease, diabetes, and coronary artery disease were associated with increased risk in all age groups. In the presence of these conditions, increased the risk of COVID-19 associated hospitalization by anywhere from 1.6 to 8.8 times, depending on the age group. And other conditions such as stroke, COPD, severe obesity, and current smoking were also associated with increased risk in some age groups. Except for COPD, the relative risk of COVID-19 associated hospitalizations in adults with and without select chronic conditions declined with age. Next slide. As with children, significant proportions of adults hospitalized due to COVID-19 experience severe outcomes, with the proportion experiencing ICU admission shown in tan, invasive mechanical ventilation shown in blue, and in-hospital deaths shown in red. Approximately 1 in 5 patients in all adult age groups were admitted to the ICU, while in-hospital death was more common among adults 50 years and older. I do want to note that the proportions on these slides are only in-hospital deaths. We've shown from previous analyses that deaths after discharge from a COVID-19 associated hospitalization are common among older adults, with a significant proportion occurring within 30 days of hospital discharge, and including among those discharged to hospice. Next slide. This slide is similar to the vaccination status slides shown for pediatrics, and it shows the proportion of COVID-19 associated hospitalizations by vaccination status among adult age groups for the 23-24 season. Among adults 65 years and older, highlighted in the box on the far right, 50% of those who were hospitalized had received neither the 22-23 vaccine or the 23-24 vaccine. About 26% of adults 65 years and older who were hospitalized with COVID had received the recommended 23-24 vaccine prior to admission, but the majority had not. Next slide. One particularly vulnerable group that I want to highlight is nursing home residents. In the 23-24 season, nearly a quarter of adults 75 years and older who were hospitalized with COVID were long-term care facility residents, indicating that they're at much higher risk of severe COVID-19 disease. However, as these data from an MMWR published by the National Healthcare Safety Network was published during this season, only 30% of nursing home residents had received the 2024-25 COVID-19 vaccine. Next slide. So in summary, rates of COVID-19 hospitalizations are highest among the oldest age groups, with adults aged 75 years and older accounting for about half of all adult hospitalizations. COVID-19 associated hospitalization rates have decreased over time, but we've seen for the most recent season that we have complete data that in adults 75 years and older, they still remain very high and were higher for all other adult age groups, even compared to previous seasons. In addition, the risk of hospitalization with COVID-19 remains during the summer months. And most patients that were hospitalized for COVID-19 had not received the most recent vaccine prior to hospitalization. Next slide. There are some underlying conditions that increase the risk for COVID hospitalization among adults. with chronic kidney disease, diabetes, and coronary artery disease increasing risk in all adult age groups. But in general, the relative risk of COVID-19 hospitalizations among adults with or without conditions declined with age for most but not all conditions examined. So with that, I will conclude my talk, and I think we were taking questions later, so I'll hand it back to Dr. Talbot.
So Dr. Lynn Gellis will talk about vaccine effectiveness updates.
Thank you. Today I'll be presenting COVID-19 vaccine data to inform the policy questions under consideration by ACIP for the 25-26 season. I'll start with some context for interpretation of VE and information on the 24-25 COVID-19 vaccination coverage. I'll then present VE methods for 2 CDC vaccine effectiveness platforms included in the presentation, and then interim estimates of 24-25 COVID-19 VE. Patterns of prior infection can impact measured vaccine effectiveness. This graph provides some context specifically for interpreting VE of 24-25 COVID-19 vaccines by showing the proportion of persons with infection-induced immunity by age group during October to December 2023, that is about 8 months before introduction of the 24-25 vaccines. During this period, all adult age groups had high rates of infection-induced immunity, above 70% for all age groups and close to 90% for those aged 16 to 64 years. Past infection can provide some protection from future infection, and VE findings should therefore be interpreted as the added benefit provided by COVID-19 vaccination in a population with a high prevalence of infection and vaccination-induced immunity. Here we see data on uptake of 2023-24 and 2024-25 COVID-19 vaccines through the fall of each year. The light blue line shows coverage during the fall of 2023 for the 23-24 vaccines, and the dark blue line shows coverage during the fall of 2024 for the 24-25 vaccines. In the left-hand graph, we have uptake for all adults aged 18 years and up, in the middle for adults aged 65 to 74 years, and on the right for adults aged 75 years and up. Note that vaccines were available about 3 weeks earlier for the 24-25 season compared to 23-24. We can see that coverage was similar across years for all adults, but slightly higher in older adults for the 24-25 season. Coverage for the 24-25 vaccine topped out at just under 25% for adults 18 and up, and at about 41 to 47% for the older adult age groups. I'll now go through some high-level methods for COVID-19 vaccine effectiveness. First, a note here on how we measure vaccine effectiveness. When COVID-19 vaccines were first released, we measured absolute VE, which compares the frequency of health outcomes in vaccinated versus unvaccinated people. Absolute VE has most often been used to measure VE during the era of original monovalent and bivalent COVID-19 vaccines. During the bivalent era, however, we also measured relative VE, which compares the frequency of health outcomes in people who received one type of vaccine to people who received a different vaccine. For example, people who received a bivalent dose versus those who only received the original monovalent COVID-19 vaccine. Generally, for the 24-25 COVID-19 vaccines, we've combined absolute and relative VE and measured protection as the frequency and disease in those who received a 24-25 vaccine to those who did not, regardless of past vaccination or infection. In other words, the comparison group for the 24-25 VE analyses that I'll share today includes people who were unvaccinated, as well as those who received original monovalent, bivalent, and 23-24 COVID-19 vaccine doses. Of note, this is similar to how seasonal influenza vaccine effectiveness is measured each year. The first VE platform included today is the VISION network, a multi-site network of electronic health records at over 300 emergency departments and urgent cares and over 200 hospitals. VISION uses a test-negative design and includes eligible adults with COVID-like illness and a clinical test within 10 days before to 72 days after their encounter. Adults age 18 years and up with COVID-19-like illness are included in the analyses presented today. Cases are those with a positive NAT or antigen for SARS-CoV-2 and no positive RSV or influenza test result. Controls are those with a negative NAT test for SARS-CoV-2 and no positive NAT test for influenza or RSV, depending on age. Vaccination is documented by electronic health records and state and city registries. The second platform included today is the Ivy Network, a multi-site VE platform in 26 hospitals in 20 U.S. states that, like Vision, uses a test-negative design. Unlike Vision, Ivy uses an active enrollment design with patient interviews and swabbing of enrollees. Participants were adults aged 65 and up, hospitalized with COVID-19-like illness. Cases have a SARS-CoV-2 positive NAT or antigen test, and controls were negative for SARS-CoV-2, influenza, and RSV by RT-PCR. Vaccination history is ascertained through EMRs, state and local vaccine registries, and self-report, and specimens are collected for central testing and sequencing. I'll now present results from these two VE platforms. This slide shows the patient populations included in the analyses I'll present. First, above the top, you can see each of the three analyses: Vision, emergency department and urgent care encounters in adults aged 18 years and up, Vision hospitalizations in adults ages 65 years and up, and IV hospitalizations in adults aged 65 years and up. First, you can see that the median age for emergency department urgent care encounters was lower in the mid-50s compared to the hospitalization analyses in both platforms, which had median ages in the high 70s. Keep in mind that the only analysis we'll share today that included adults aged 18 to 64 was the Vision emergency department urgent care analysis. Younger adults were excluded from the hospitalization analyses for both Vision and IV because of lack of statistical power, due to both lower baseline hospitalization rates and lower COVID-19 vaccine uptake in this age group. The Vision hospitalization analysis also includes VE for adults aged 65 years and up with immunocompromising conditions. This slide shows VE of the 24-25 COVID-19 vaccines against COVID-19 associated emergency department and urgent care encounters by age group. The top block shows VE for all adults aged 18 and up during those 7 to 119 days after the dose and split by time since dose, 7 to 59 days and 60 to 119 days. The middle block shows the same information for adults aged 18 to 64 years and adults aged 65 years and up. The first column shows COVID-19 cases. The second data column shows COVID-19 controls. The third column shows median time since the last dose among those vaccinated. And then finally, the last column and forest plots show the VE estimates. Note that among the referent group, those who did not receive a 24-25 COVID-19 vaccine, it's been almost 100 days or almost 3 years since receipt of their last COVID-19 vaccine dose for all adults. VE among all adults against COVID-19 associated ED-UC encounters was 33% for the 7 to 119 days since receipt of a dose, 36% for the 7 to 59 days, and 30% for the 60 to 119 days since receipt of a 24-25 COVID-19 vaccine dose. VE among younger and older adults was similar. This slide shows VE against COVID-19 associated hospitalization among adults aged 65 years and up without documented immunocompromising conditions in the Vision and IV networks. This slide is laid out the same as the previous slide, except instead of age groups, it shows Vision adults in the top block and IV results in the bottom block for ages 65 years and up for both platforms. VE was almost identical across the two networks, providing reassurance of the results. During the 7 to 119 days since a dose, the point estimate was 45% in Vision and 46% in IV. VE was 42% during the 7 to 59 days since a dose in both networks, and 48% in Vision and 47% in IV for the 60 to 119 days since a dose. Finally, this slide shows VE against COVID-19 associated hospitalizations among adults aged 65 years and up with immunocompromising conditions in Vision. There was not enough statistical power to estimate VE by time since dose for this group, But for the 7 to 119 days since a dose, VE was 40%, close to that in immunocompetent adults, and providing reassurance the vaccine is working in immunocompromised adults. 2024-2025 COVID-19 vaccination provided additional protection against COVID-19 associated emergency department and urgent care visits and hospitalizations compared to no 24-25 COVID-19 vaccine dose. 24-25 COVID-19 vaccination also provided additional protection against COVID-associated hospitalizations among adults aged 65 years and up with immunocompromising conditions. Finally, just a reminder that VE should be interpreted as the added benefit of 24-25 COVID-19 vaccination in a population with high levels of infection-induced immunity, vaccine-induced immunity, or both. Prior SARS-CoV-2 infection contributes protection against future disease, though protection wanes over time. An increase in SARS-CoV-2 circulation in the United States during late summer 2024, just before 24-25 COVID-19 vaccines were approved and authorized, may have resulted in higher population-level immunity against JN1 lineage strains, which could have resulted in lower measured VE than in a population with less recent infection. I'd like to thank the numerous colleagues from CDC and collaborators with the Vision and Ivy networks who contributed to this presentation. Thank you.
Thank you. We're going to stop for questions. These are questions just for Dr. Havers and Dr. Link Gallas. Any questions that came from the talks before, we'll wait till after. And my Zoom just crashed, and so I'm going to ask Dr. Wharton to see if she can pull up so I can see the names of people who have questions. All right. Dr. Asturias, please start.
Thank you, and appreciate these two presentations. And I'm very encouraged that we are focusing more on children, as I think one of the major myths that we have to debunk is that young children do not have a risk of severe disease and hospitalization from COVID-19. And I think your data show that these trends are not decreasing. So it's consistent that as we have new cohorts of unprotected infants being born every year, we probably have to adjust our current recommendation, given that they don't specify the importance of vaccinating young infants and children to avoid this morbidity and mortality. I have to point out that 70% of your hospitalizations in children are occurring in less than 4 years of age, and half of them don't have any associated medical conditions. So I know that we're going to move to a presentation where we're going to be discussing this, but I think it's so important for all of us to sort of make sure that we value children as a prime, group that needs to be protected better than what we are doing so far. So, over.
Thank you, Dr. Lair.
Thank you for this presentation. I'm always interested in how chronic kidney disease has a high risk of getting severe COVID disease. Can you comment on how they defined chronic kidney disease? Was it by creatinine clearance? Was it class 3 or class 4? Thank you.
Yeah, that's a good question. As I mentioned, without going too much into the details of how this analysis was done, we do think that the sort of relative risk of chronic kidney disease may be slightly exaggerated in this analysis because of the way the data is collected in the behavioral risk factor surveillance system. It's based on self-report, and that could skew potentially the denominator there. So I do think there is a real increased risk of having chronic kidney disease. The magnitude of the risk compared to other underlying medical conditions may be a little bit challenging to compare. I don't know if that question makes sense, but it's based on, for the COVID-19 hospitalizations, it's based on medical chart review. If chronic kidney disease is noted in there, there's not a strict criteria. And then for BRFSS, it's based on self-reported medical conditions.
Thank you.
Dr. Gamboge?
Thanks very much for the excellent presentations. I was wondering, do we have any data to show that the uptake of additional doses in immunocompromised patients has improved nationally since the last data that was shared? And the second question specifically for Dr. Gallas, slide 13. I understand the sample size was not large enough to examine time since vaccination, and it would make sense that it wasn't large enough to even look at the number of doses, but I just wanted to see if it was examined that way. Thank you.
Yeah, I think I'll defer your first question to our colleagues from Immunization Services, which should be on the line. For your second question on vaccine effectiveness, we did look at additional doses. Generally, we've seen that there's relatively low uptake within our VISION population of additional doses. And just given the timing of when the analyses were completed, there wouldn't have been too terribly many people in the population that were eligible for a second dose or subsequent doses during the analyses. It's something that we'll continue to monitor over the rest of the year, though.
Dr. Hogue?
Yeah, just a really quick comment on the fact that 90% of the children hospitalized with COVID-19 were unvaccinated is not actually really going to tell us much about the effectiveness of the vaccine, considering almost 90% of children in general are unvaccinated. I believe it's 87%. Most recently, 86% the year before, and that the same applies to adults. So it's important to adjust for the baseline rate of vaccination among the population.
Just as a comment to that, I think we were just showing the vaccination status of hospitalized children, but that slide was not intended to reflect any vaccine effectiveness. I think for those data, I would defer to Dr. Link-Ellis's approach and the data that she showed.
Yeah, sure. And we didn't include children here because of the lower baseline rates of disease, but we'll continue to monitor that over the rest of the year. And I would just add that the design of our vaccine effectiveness studies is what allows us to control for baseline coverage. So the referent group is the unvaccinated population, which gives us the number or rate or risk of disease in unvaccinated people. And then the comparison there is that rate or risk of disease in the vaccinated versus the unvaccinated populations.
Thank you. And Dr. Joseph, you have the last one before we move on.
Thank you so much. This is Naiva Joseph with the American College of Obstetricians and Gynecologists, and I appreciate the data presented today. I just wanted to highlight again, as has been mentioned by others, the high rate of hospitalization in young children, and especially, the previous CDC data has shown a really high rate amongst infants 6 months and younger who are ineligible for vaccine, which small studies have shown a benefit for boosting in pregnancy as a way to protect those infants who are not otherwise eligible for vaccination, and would look forward to further data that might demonstrate the effectiveness of vaccination of maternal immunization against infant protection. Thank you. Over.
Yeah, thank you for that comment. This is Dr. Havers. I do want to emphasize in this presentation we were largely focusing on children and infants who are older than 6 months, but you are correct in that the hospitalization rates for infants less than 6 months who are protected through maternal vaccination during pregnancy are by far the highest among all the pediatric age groups. So that is a very important point that I hadn't emphasized. Thank you.
Thank you. And now we're going to move on to our work group considerations.
Hi, everyone. My name is Lakshmi Panayotopoulos. I'm one of the co-leads of the ACIP COVID-19 work group. I'll be presenting work group considerations for use of the 2025-26 COVID-19 vaccines. In this talk, I will briefly review the current recommendations for 2024-25 COVID-19 vaccines, policy options for the 2025-2026 COVID-19 vaccine recommendations, supporting data and workgroup interpretations, and pose discussion questions for the committee. As a reminder, in October 2024, ACIP voted to recommend an additional dose of 2024-25 COVID-19 vaccine for adults ages 65 years and older, and for everyone ages 6 months and older with moderate and severe immunocompromise. People who are immunocompromised are also eligible for additional doses under shared clinical decision-making. The April 2025 meeting agenda is listed and no votes are scheduled. And the proposed schedule for June 2025 includes votes on the 2025-26 COVID-19 recommendations, including additional dose recommendations for eligible groups. Now I will briefly review the 2024-25 COVID-19 vaccine policy. This is an overview of the routine COVID-19 vaccine schedule, which is straightforward for the majority of the population. As a reminder, children ages 6 months to 4 years who are unvaccinated should receive a multi-dose initial series with the 2024-25 COVID-19 mRNA vaccine. Those who have previously completed an initial series should receive 1 dose of a 2024-25 mRNA vaccine from the same manufacturer as the initial series. People ages 5 to 64 years should receive 1 age-appropriate dose of the 2024-25 COVID-19 vaccine, and people ages 65 years and older should receive 2 doses of any 24-25 COVID-19 vaccine spaced 6 months apart. People who are moderately or severely immunocompromised and unvaccinated should receive a multi-dose initial vaccination series with an age-appropriate 2024-25 vaccine and receive 1 dose 6 months after completing the initial series. Those who have previously completed an initial series should receive 2 doses of an age-appropriate 24-25 COVID-19 vaccine spaced 6 months apart, and they may receive additional doses under shared clinical decision-making. Now we will discuss policy considerations for the 2025-26 COVID-19 vaccine. When considering the policy options for the 25-26 COVID-19 vaccine, one important consideration is whether to maintain the current multi-dose initial series for people ages 6 months to 4 years and people with immunocompromise. Another consideration is whether to maintain the universal recommendation for everyone ages 6 months and older or move to a risk-based recommendation. A third option is a combination of a risk-based and universal vaccine recommendation. An example of this is a risk-based recommendation for people ages 6 months to 64 years and a universal recommendation for people ages 65 years and older. There are also considerations for groups who are currently recommended to get more than 1 dose a year. Most people ages 65 years and older are recommended for 2 doses a year. Some may need more, specifically those that are previously unvaccinated and receiving Novavax or are immunocompromised. And people ages 6 months and older who are moderately or severely immunocompromised are recommended to get an initial series followed by 2 doses a year and may receive additional doses. If a risk-based recommendation is to be considered for 2025-26, defining who's at risk could be complex. How much increased risk is sufficient for a recommendation? There are certain groups at increased risk of severe outcomes based on age, underlying conditions, and pregnancy status, and groups at increased risk of exposure, including healthcare workers and people living in long-term care facilities and other congregate settings. The CDC's current list of conditions that conclusively increase the risk of severe COVID-19 is extensive and predominantly based on pre-Omicron data. The list of conditions brings up the question, how much of the population has one of these conditions? An analysis of U.S. adults with conditions that put them at higher risk of severe illness due to COVID-19 was carried out using medical claims data, consumer data, the Behavioral Risk Factor Surveillance System, and the National Health Interview Survey to enumerate the U.S. population with conditions that put them at increased risk of severe illness from COVID-19 using multi-level regression modeling. Notably, the conditions highlighted by the red boxes were not included in the analysis. The analysis showed that the population of U.S. adults with at least one condition that puts them at higher risk of severe illness from COVID-19 generally increases with age. Approximately 74% of all U.S. adults 18 and older had at least one condition. And as a reminder, this analysis did not include people with Parkinson's disease, physical inactivity, and steroid use or other immunosuppressive medications, which is expected to lead to larger percentages across all age groups. Now I will present a summary of supporting evidence that has been presented to the work group. We will start with a review of current COVID-19 epidemiology. This slide shows the current weighted and model-based projected nowcast estimates for SARS-CoV-2 circulation in the United States, showing that the XEC and LP.8.1 strains from the JN1 lineage are predominant. Weekly rates of COVID-19 hospitalizations peaked in January and appear to be decreasing. Looking more closely at pediatric hospitalizations, we see that children ages 0 to 17 during the fall and winter of 2024-25, rates of RSV and influenza hospitalizations represented by the solid purple and blue lines were higher than the rates of COVID-19 hospitalizations represented by the solid magenta line. Additionally, the rates of COVID-19 associated hospitalizations this winter were lower than they were during the corresponding months in 2023 to 2024, seen in the dotted magenta line. COVID-19 associated deaths are also decreasing and remain lower this winter than they were in late summer and fall of 2024. When looking at the leading causes of death among children 0 to 17 years old, COVID-19 has decreased from number 8 in 2021 and 2022 to number 12 in 2023. When looking at the leading causes of death among adults, COVID-19 has decreased from number 3 in 2021 to number 4 in 2022 and number 10 in 2023. This graph shows the total number of COVID-19 deaths between September 23 and August 2024 by age group. The majority of deaths occur in adults ages 65 years and older. This graph shows the number of COVID-19 and influenza deaths among people ages 0 to 17 years between September 2023 and August 2024. For children less than 1, the number of deaths from COVID-19 were higher than the number of deaths from flu. However, for children ages 1 to 17, there were more deaths from influenza than from COVID-19. Looking at trends from the 2023 to 2024 year to the 2024-2025, there was no difference in vaccine recommendations, and there was similar vaccination coverage for children and adults. Vaccine coverage in people ages 65 years and older increased, while vaccine effectiveness in adults 18 and older was similar. And finally, cumulative hospitalization rates decreased overall. This slide shows the most recent data available on seroprevalence among children from September 2021 through the end of 2022 based on blood collected by commercial laboratories. A large increase was seen with the emergence of Omicron starting in December 2021, with smaller increases seen by the end of 2022. By the end of 2022, approximately 90% of children aged 2 and above, 82% of children aged 1 to 2, and 64% of infants less than 1 year old have been infected. To evaluate population immunity, a study looked at spike antibody levels in a nationwide cohort of over 100,000 blood donors ages 16 years and older. The study showed that a higher number of cumulative SARS-CoV-2 infections and COVID-19 vaccinations lead to higher antibody levels, but with smaller incremental increases in antibodies with each exposure, especially after 4 cumulative events, as shown in the graph. Now I will discuss long COVID, which remains a significant public health threat. National surveys in 2023 estimated approximately 9.2 million adults and 0.3 million children in the U.S. had long COVID. Among adults, 3.6% reported long COVID symptoms, and 8.4% reported ever having long COVID. Among children, 0.4% reported long COVID symptoms, and 1.4% reported ever having long COVID. COVID-19 mRNA vaccination is associated with a reduced risk of long COVID following COVID-19. Among children 5 to 17 years, completion of the primary vaccine series prior to infection was associated with a reduced likelihood of long COVID symptoms by 57% for one or more symptoms, 73% for two or more symptoms, and 72% for respiratory symptoms. Among adults, 3 doses of the original monovalent vaccine prior to infection was associated with a reduced likelihood of long COVID symptoms by 63% for GI symptoms, 44% for neurologic symptoms, and 52% for other nonspecific symptoms. Here we show estimates of multisystem inflammatory syndrome in children, or MISC incidence per 1 million person years, done using population estimates from U.S. Census data. You can see that the incidence per 1 million person years was 6.8 in the pre-Delta period and had decreased to 0.08 in 2024. You can also see there was a brief shift in MISC cases to younger children in 2022 and has since increased back up to 9 years old in 2024. Similar decreases in MISC incidence and a transient shift to younger age groups in 2022 were observed in other countries as well, including England, Australia, and Israel. This table shows COVID-19 vaccination status for children with MISC in 2023 and 2024. Although 95% of children with MISC in 2023 and 99% in 2024 were eligible to receive a COVID-19 vaccine prior to their illness, only 19% in 2023 and 26% in 2024 received any vaccine dose. Of these vaccinated children, 65% in 2023 and all in 2024 received their last vaccine dose greater than 12 months prior to their MISC. Now I will present data on COVID-19 vaccine and myocarditis. As a reminder, all 3 COVID-19 vaccine brands have warnings and precautions about myocarditis and pericarditis. This graph shows data from the Vaccine Safety Data Link to illustrate the trend in the observed rate of myocarditis following mRNA COVID-19 vaccination from 2020 through 2025. A statistically significant increased risk of myocarditis was observed with the original monovalent vaccine, primary series, and booster doses. There was no increased risk observed with the doses administered in subsequent years. This table shows details of VSD's vaccinated concurrent comparator analysis for the 2024-2025 vaccine. The incidence of myocarditis and pericarditis in the post-vaccination risk interval is not different than the incidence in the comparison group, and the VSD has not detected a statistical signal for myocarditis and pericarditis following the 2024-25 COVID-19 vaccine to date. The Vaccine Adverse Event Reporting System also continues to monitor reports of myocarditis after COVID-19 vaccines. Among people ages 12 to 39 years, there have been 4 verified cases reported with the 24-25 vaccine. The reporting rates are similar to the expected background rates of less than 2 cases per million doses. Now, some of the clinical aspects of myocarditis following COVID-19 vaccine. The MOVING study assessed cardiologists and healthcare provider assessments of recovery in 385 persons ages 12 to 29 years old in the 90 days following myocarditis after COVID-19 vaccine, and found that 81% of patients were considered fully or probably recovered. In the same study, 50% of patients self-reported at least one lingering symptom at 3 months. A large study comparing post-COVID-19 vaccine myocarditis to post-COVID-19 myocarditis and conventional myocarditis found that the complications with post-vaccine myocarditis were lower than in the other 2 categories. To summarize the myocarditis data, an increased risk of myocarditis following COVID-19 vaccines was observed during 2020 to 2022 following the primary series and first booster doses. No increased risk was observed in the VSD and bears with the 2022-23 and 2023-24 vaccine or the 2024-25 vaccine to date. The acute clinical picture following myocarditis after COVID-19 vaccine tends to resolve quickly, and post-COVID-19 vaccine myocarditis associated with less severe cardiovascular events than post-COVID-19 myocarditis and conventional myocarditis. Now I will discuss data on risk-based versus universal vaccine recommendations and how this may impact vaccine coverage. The work group raised concerns about moving to a risk-based only vaccine recommendation and how this would impact COVID-19 vaccination coverage among people with high-risk conditions. Because influenza vaccine was initially recommended for people with high-risk conditions and moved to a universal recommendation in 2010, it was used as an example of what could potentially happen to coverage among people with high-risk conditions if COVID-19 vaccine recommendations were to be risk-based. For influenza vaccine, coverage among 18 to 49-year-olds with high-risk conditions increased approximately 2 percentage points between 2008 to 2009 and 2010 to 2011, but plateaued thereafter. No significant changes were seen among people with high-risk conditions when vaccine recommendations targeted people with high-risk conditions only compared to a universal vaccine policy. The work group also considered other vaccines that may provide information on how a universal versus risk-based recommendation could impact vaccine coverage. Hepatitis B vaccine coverage among adults with risk factors remained below pre-pandemic coverage after moving from a risk-based to a universal recommendation in 2022. And a comparison was also made between zoster vaccine, which is universal for ages 50 and older, and pneumococcal vaccine, which was previously recommended for risk groups among the same ages. Vaccine coverage among adults universally recommended for zoster vaccine was approaching pneumococcal vaccine coverage among high-risk adults by 2023, despite a long-standing pneumococcal vaccination recommendation for high-risk adults. It's unclear how a change from universal to risk-based recommendations may impact COVID-19 vaccine coverage among people with risk conditions. So now I will go through some parental vaccine confidence data. Among children ages 6 months to 17 years, vaccination rates are approximately 12% this year, which is similar to last year. And given the low vaccination coverage among children, the work group reviewed data on parental vaccine confidence to understand barriers to vaccine uptake in children. Survey data showed that only 22% of parents of children 0 to 17 years old were asked, when asked what actions they would take to prevent their child from getting a respiratory illness, said they were very likely to get their child vaccinated for COVID, which was lower than the other options presented to prevent respiratory illnesses. Out of the parents whose children previously received 1 dose of COVID-19 vaccine, most reported the same amount of confidence in safety and effectiveness to when vaccines first came out. However, 15% of these parents reported less confidence. Among parents of children whose children have never received a COVID-19 vaccine, approximately 45% reported less confidence in vaccine safety and vaccine effectiveness compared to when the vaccines first came out. Parents of children who have never had any COVID-19 vaccine were more likely to have parents of children who have had any COVID-19 vaccine were more likely to have gotten or are planning to get the 2024-25 COVID-19 vaccine for their children compared to parents of children who have never been vaccinated against COVID-19. And finally, when comparing reasons for not getting vaccinated for COVID-19 by prior vaccination history, parents of children who were never vaccinated were more likely to report concerns about safety, effectiveness, and having a bad reaction. Of note, 15% of parents of children who have had a prior vaccine dose reported that their children has received enough doses of COVID-19 vaccine. Now I will briefly review COVID-19 vaccination recommendations from other countries. Regarding booster recommendations or doses for people who have already completed an initial series, most countries have recommendations for older adults to get vaccines every 6 to 12 months. The age cutoff for these recommendations range from 50 years to 80 years old. For otherwise healthy adults, the United States is the only country with a routine recommendation. Other countries vary on whether they have no recommendation, a discretionary recommendations, or recommendations specific to pregnancy status. For high-risk adults, most countries have a routine recommendation for a yearly vaccine. However, in Australia, this population has a discretionary recommendation. For immunocompromised adults, most countries have a recommendation to get the vaccine every 6 to 12 months. The U.S. is the only country that allows additional doses beyond a twice-a-year recommendation. Besides the United States, most countries do not recommend routine vaccination of children. Canada allows for healthy children to receive a vaccine every 12 months. For high-risk children, the UK, Canada, and US recommend the vaccine every 12 months, while Australia and the WHO do not. For immunocompromised children, most countries recommend vaccination every 6 months. However, Australia does not recommend vaccination for children less than 5 years of age. And in Australia, children ages 5 to 17 with immunocompromising conditions may get the vaccine yearly. Now I will discuss workgroup interpretations of the data. When initially presented with the 25-26 COVID-19 vaccine policy options in November 2024, the workgroup appreciated pros and cons of both a risk-based and universal vaccine recommendation. There was not yet consensus at the time on what the recommendation should be, and the workgroup did request additional information to help inform the decision-making process on risk factors for severe COVID-19, transmission and immunity, vaccine implementation and access, and cost effectiveness. Based on the information presented to the workgroup as of February 13, 2025, which included data on risk factors for hospitalization, trends in mortality, risk-based versus universal vaccine coverage, vaccine hesitancy, and COVID-19 and myocarditis, the majority of the workgroup supported a risk-based recommendation for 25-26 COVID-19 vaccination. Among workgroup members who selected a non-universal policy recommendation, almost all supported a risk-based recommendation by conditions and exposures, a universal recommendation for certain age groups, as well as permissive language to allow anyone who wanted protection from COVID-19 vaccine to get a vaccine. Following this poll, additional data on vaccine effectiveness, seroprevalence, long COVID, vaccine coverage, and MISC were presented to the workgroup, and the workgroup also received feedback on the recommendations from liaison organizations. Between March and April 2025, the AAFP, AAP, AIM, ACP, APHA, and ACOG provided feedback on moving to a potential risk-based COVID-19 vaccine recommendation. Concerns were raised regarding implementation, communication, confidence in the recommendation, and equitable access to vaccination with a potential risk-based recommendation. The workgroup was re-polled on April 3rd, and the majority of the workgroup still supported a risk-based recommendation for 2025-2026 COVID-19 vaccination. Among workgroup members who selected a non-universal policy recommendation for everyone, on April 3rd, almost all supported a risk-based recommendation by condition or exposure, a universal recommendation for some age groups, as well as permissive language to allow anyone wanting protection from COVID-19 vaccination to receive one. And this slide is a quick reminder from Dr. Havers' presentation on risk conditions in adults. We saw that some underlying medical conditions increase the risk of COVID-19 hospitalization for adults of all age groups, including chronic kidney disease, diabetes, and coronary artery disease, while some conditions such as asthma, history of stroke, COPD, severe obesity, and current smoking increase the risk among adults in some age groups. Having none of the underlying medical conditions examined decrease the risk of COVID-19 associated hospitalizations among all adult age groups. And finally, these are the questions we'd like to pose to the committee today. As far as general thoughts on universal versus risk-based recommendations for COVID-19 vaccination, are there groups that clearly should not be recommended for vaccination with the 2025-26 COVID-19 vaccine? What data would be helpful in your decision-making? Is it still helpful to have a risk-based recommendation if most of the population is considered at risk based on the current risk criteria? Should people at higher risk of infection and transmission, such as healthcare workers, be included in a risk-based recommendation? Will stable universal recommendations increase uptake with time? Are there concerns about implementation challenges with risk-based recommendations? Are there any potential unintended implications or consequences of a recommendation change? And are there key decision points that we have not captured here? So thank you to everyone who contributed to this presentation, especially my co-lead, Lauren Roper. And now we can go back to the previous slide to get some thoughts from the committee. Thank you.
Thank you. And Dr. Jameson was on the button. Dr. Jameson.
Thank you so much. Thanks for your excellent presentation. I guess with the very high proportion of adults with risk factors that you mentioned, 74%, and COVID, although it's dropped, is still a leading cause of death among both adults and children. I guess I'm surprised we're considering a risk-based recommendation, which in general we have not had a lot of success with implementing in the US. The other thing is you mentioned hepatitis B as an example where universal recommendation did not increase, but to me it's not really a relevant comparison. A relevant comparison is flu, and to decouple flu and COVID, people are just starting to understand the importance of getting their COVID and flu vaccine every year. I worry about implementation. I also worry about the feasibility of a permissive recommendation. Given healthcare financing, it may be very difficult for people to find a way to get the vaccine paid for if it's permissive. So I would, at this point, with the information presented, I would be in favor of a universal rather than a risk-based recommendation. Thank you.
Thank you, Dr. Asturias. Oh, wait, did I skip?
Dr. Laurie was before. So.
Dr. Lair.
No worries. Thank you so much for this presentation. I'm very happy that we're seriously considering a risk-based recommendation. I'm glad that we're taking this as a reasonable possibility. If you could go to around slide 14, this is the most of the population considered at risk. You had the 18 to 50-year-olds in the 60% range for the people at risk, and this just does not compute with my experience with 18 to 50-year-olds. If you go back one slide here, I don't have 60+% of 18 to 50-year-olds with any of these diagnoses, and so that just seems incredibly high. I could buy maybe 50-year-olds, definitely the elderly, but I don't think that's accurate for probably ages 5 through 50. I also, even though I'm very much in favor of considering a risk base, I am concerned about the feasibility of it and the message it might be sending. COVID is still a fairly dangerous disease and very, very common. We're not talking about 10 cases of Mpox. We're talking about thousands of hospitalizations and deaths. And so even though I'm in favor of a risk base, I still have my hesitations. So thank you very much.
Dr. Asturias.
Thank you. And a wonderful presentation. And I'm just going to concentrate on what data will be helpful. I think, given that I'm very much concentrating in the young infants and children who I think we have not taken care as we should to protect them against COVID. Data on the current transfer of maternal antibody will be useful. I think most of the data that we have comes from the previous years where basically we were trying to understand if that was offering of protection, but if there was any possibility of getting current data, given that most women now have been either infected or vaccinated, will be interesting. And then more granular data on the hospitalization of children in the first year of life, especially, why are these kids getting hospitalized? I think some of our data from influenza shows that they get hospitalized mainly for fever and irritability. And even though some of them end up in the ICU, it will be interesting to sort of see what the causes of hospitalizations are. So, over. Thank you.
Dr. Brooks.
Yes. First, I think it'd be helpful to go back to the slide. As Dr. Sturris referenced, that's what we're looking for, more data. And that was that last slide, 68, something like that. No, not that one, all the way back to the end. And what I would want to see is modeling around long COVID. I mean, it was shown that there's about a 3% prevalence incidence of 8%. The slide where you were asking for questions, so I think I want to say the last slide. And even though, let's say, the rate of COVID among, let's say, a healthy 30-year-old is low, if they have the potential to get long COVID, which again was lower numbers, but still the absolute numbers may be high versus the percentages. I am concerned about that. My primary concern through all of this at this point now is still long COVID. So what I would like to see is some modeling regarding the absolute numbers of long COVID related to the lower age groups may not receive a recommendation to get vaccinated.
Dr. Brewer?
We received some feedback just in one of the questions that there's a concern about implementation with a risk-based approach. This committee, and I can't remember this in the work group or if this general committee, has seen data that show that, well, I mean, maybe it doesn't show, but there's not clear evidence at all that risk-based approaches are less effective. It's certainly something we've all talked about and something that some of the companies have shared for many years, but the data supporting that claim are not really there. And so I used to believe that risk-based approaches were problematic, but based on the data that I saw, I don't know that I can support that conclusion. It may be true from our best guess, but it's not an evidence-based conclusion.
Thank you. Ms. Moser.
Thank you. I have two points. One related to the question at hand, which is that I am in support of the risk-based idea. I'm glad we're exploring that. I do think when we think about which groups and age was mentioned, that we should, I agree with Dr. Astorius, make sure that we're keeping the youngest of children on our radar because they represent a new group of large group of susceptibles to this virus every year. And if we can vaccinate those kids, we may decrease that under 1-year-old hospitalization rate. And we may also protect them against long COVID on their first exposure to the virus, albeit those data aren't as strong. And I think it's that vaccinating those kids in the younger time period also gets us away from the concerns that we had about vaccinating adolescents around myocarditis. So those are my comments on this slide. While we're on the COVID topic, I did want to acknowledge the many members of the public who took time to submit comments for this week's meeting. And in particular, there were a significant number of comments that people submitted regarding the change in licensure status for Novavax that was anticipated to occur a few weeks ago. And since I know that's not something that our committee has on its plate, but it's something that the FDA does, I wondered if, and there are no, as far as I saw on the agenda, no ex officio reports this week. So if I missed that, I apologize. But I was wondering if while we're talking about COVID, maybe our FDA liaison would be able to offer an update for the members of the listening public who have questions about what's happening with Novavax.
Dr. Hogue, do you have a moment?
Yes, that is a good question. I don't know to what extent I'm allowed to give an update on that, but there will be an update coming out publicly very soon.
Great. And Dr. Freihofer, don't go anywhere. I have one quick question also for Dr. Hogue. We get lots and lots of comments regularly about why have we not approved or why do we not recommend Novartis for kids less than 12? No, Novartis. Novavax. Oh, never mind. I've just been corrected. We're going to Dr. Freihofer.
Sandra Freihofer, the American Medical Association. Speaking as a practicing physician, I see patients in the office every day. I'm an internal medicine physician, so a lot of my patients are older and fragile. As a new grandmother, I also worry about the very young. And I go back to that slide that you showed that 74% of patients have at least one risk factor. And then I go to what it's like to be in practice. And you might have heard the expression KISS, K-I-S-S, keep it simple. I'll let you figure out what you want the second S to be. But the reality is most of these vaccines, certainly for adults, are being given in pharmacies. The risk-based recommendations are more difficult for pharmacists because patients have to self-declare their illnesses, or the pharmacists have to check their medication list. And patients may not feel comfortable with that. So I am on the COVID vaccine work group, and I was one of the 19% that did suggest a universal recommendation, and that is why.
Thank you. Dr. Lair.
Thank you. I'd like to comment on Dr. Brewer's comment. In the pneumococcal work group, we've been showing data that it's pretty clear that the risk-based recommendation for 50 to 65 was actually only about 20% of uptake, whereas the age-based recommendation for 65 and over was about 65% uptake. So for me, that does suggest that a risk-based recommendation actually does not have as much uptake as a universal recommendation or age-based. It still doesn't mean that I don't agree with the risk-based, but I did want to at least put that comment out there. Thank you.
Any other questions? Fantastic. Okay, we will come back at 1:30. Oh, sorry, we didn't do pneumococcus. I'm going to get some caffeine at the next break. Can we go back and let's go back. Don't run away, y'all. We're going to talk about the pneumococcal vaccine. And Dr. Kobayashi, could you?
Before we do that, do you want to see if there's any residual questions from the earlier discussion?
Oh, yes. Actually, Dr. Wharton also reminded me, were there any residual questions left over from the original conversation about the Moderna mRNA? Oh, wow. Dr. Cambodge.
Thanks very much, Dr. Talbot. Dr. Rescala, could you comment on if there were any comparisons on T-cell responses between 1273 and 1283? Thank you.
Thank you for your question. Just making sure you can hear me okay.
Can't hear him.
Yep. Okay. Excellent.
Yeah.
Testing if you can hear okay.
Perfectly.
Okay, excellent. Thank you. So thank you for the question. So we have looked at T-cell responses following in our phase 2 study. We looked at mRNA 1283 at the dose that was tested in the phase 3, and also compared that to the T-cell responses for 1273 or Spikevax. We showed comparable responses between mRNA 1283 and Spikevax in terms of CD4 and CD8 responses that persisted for the duration of the study, which was 366 days. So comparable responses.
Wonderful. Thank you.
Thank you, Dr. Schechter.
Thank you. I had a question around the seeing the age risk groups in the last presentation for myocarditis risk. And on slide 6 of the the presentation, I think there was age breakdown for adolescents and then 18 to 64. I'm just wondering if not now, over the next days, could get a breakdown of sort of the 18 to 30 or 18 to 40 sample size in terms of the population that might have been at higher risk for myocarditis in the trial. Thank you.
Okay. So there have been no cases of myocarditis or pericarditis observed throughout the program, but we'll be happy to come back to the work group and share a breakdown of the demographics in that 18 plus population.
Thank you.
Thank you. Dr. Kurilla. Dr. Kurilla, we can't hear you. Dr. Kurilla, I'm going to go to Dr. Hogue, and then hopefully we can come back and you'll be able to hear you.
Yes, thank you. So this is a question about the Moderna study for Mr. Rizkallah. My question is, I was interested that this was a non-inferiority study and wondering how you were able to determine the efficacy of the Spikevax vaccine, which you were comparing mRNA 1283 to at the time of the study, considering the amount of underlying population immunity prior infection, if you were relying on real-world data, which tends to be biased by healthy vaccine bias, or just neutralizing antibodies, which have not been clinically validated in people with prior infection. I'm just curious how you got your efficacy versus of Spikevax versus like hospitalization, COVID death, and long COVID, or if you were able to estimate that.
So the phase 3 study was comparing the relative vaccine efficacy between the two arms, based on CDC defined COVID-19.
So I guess my question is, how do you know if the Spikevax vaccine is effective and how effective it is if you're doing a non-inferiority study? Like, how can we determine what the new mRNA 1283 efficacy is if we don't know the efficacy of what you're comparing it to?
Yes, hi, this is Darren Edwards. I'm the program lead for our COVID vaccines. So each season, as we update our strain composition for our Spikevax product, we do measure vaccine effectiveness over the course of that season. So we have established and continue to establish the vaccine effectiveness profile each season for each variant composition, including the one that was included in this trial.
Thank you very much. Dr. Kurilla? Okay, we're gonna have to try again later. Hopefully we get your question answered. All right, we're going to move to the pneumococcal vaccine discussion. And Dr. Kobayashi, I believe it's actually your turn this time.
Okay. Thank you very much, and good afternoon. On behalf of the pneumococcal vaccines work group, I will present our proposed work plan and next steps. Okay, first, I'd like to introduce our current work group members, led by Dr. Jamie Lear, who has been serving as the chair. Additionally, ACIP voting members on our work group include Dr. Minnie Kamboj, Dr. George Kuchel, and Dr. Robert Schechter. We have also the following ex officio members, liaison representatives, and consultants, and I would like to thank all the work group members for their valuable contributions and dedication. And here are the CDC contributors who support the work group activities. The pneumococcal work group's terms of reference are to review evidence to inform the use of new pneumococcal conjugate vaccines in U.S. adults and children. In the past 40 years, there have been multiple updates to the U.S. pneumococcal vaccine program, especially within the past 5 years. during which 3 new pneumococcal vaccines were licensed for use. The most recently licensed vaccine was the 21-valent pneumococcal conjugate vaccine, or PCV21, for adults, which was last year. However, the work group acknowledges that there are gaps in current pneumococcal vaccine recommendations. One such gap concerns pregnant women. This table from the adult immunization schedule shows that there is currently no guidance for use of pneumococcal vaccines in pregnant women who have underlying conditions or risk factors that increase the risk of pneumococcal disease. Additionally, ACIP has never specifically voted on pneumococcal vaccine use among hematopoietic stem cell transplant recipients. The clinical guidance for pneumococcal vaccine use was last updated in 2023 after PCV15 and PCV20 were licensed. Currently, there's no guidance regarding PCV21 use in this population. Since a formal review of literature regarding pneumococcal vaccine use in pregnant women and hematopoietic stem cell transplant recipients has not been presented to ACIP, we have been conducting such a review. And we plan to present a summary of our findings and propose language for updated clinical guidance for the committee's review and feedback at the June 2025 ACIP meeting. Thank you. That is the end of my update.
Fantastic. Okay. Just a second. Okay. So 2 o'clock. All right. So we're going to have a nice long break till 2 o'clock. I'm going to go get some more caffeine, and I'm looking forward to seeing everyone at 2 o'clock.